today is about Class 2 Division 2 malocclusion. Last lecture we discussed Class 2 Division 1, and today we will discuss Class 2 Division 2. So according to the British Standard Institute, again, Class 2 Division 2 is when the lower incisal edge occlude palatal to the cingulum plateau of the upper incisors, while the upper incisors, and usually the lower, but mainly the upper incisors, are retroclined, and the overjet will be usually minimal, could be increased though, and will have a deep overbite. Van der Linden, he is also subdivided this Class 2 Division 2 into Type A, in which the upper central incisors and lateral incisors are tipped palatally, and the maxillary canine is well aligned in the dental arch, it's not displaced buccally. And Type B, in which the upper incisor is only tipped palatally while the lateral incisors are labially tipped, in which here the lateral incisors are shorter and the lower lip is only retroclining the upper central incisors. And Type C, in which it retroclines the incisors, all of them central and lateral, while the canine is buccally displaced and located outside the line of the arch. So why is the etiology? Why do we have Class 2 Division 2? Number one is genetics, and out of all the malocclusion, Class 1, Class 2 Division 1, Class 2 Division 2, and Class 3, the strongest association with genetics is for Class 2 Division 2. And they found that there is a high concordance in twin studies that will suggest that we will have an autosomal dominant with incomplete penetrous or polygenetic mode for inheritance for a Class 2 Division 2. So where this evidence came from? They studied 20 monozygotic twins, which means these are identical twins. And because these patients usually, or these people who are identical twins, they have identical genes. And what they found, that all the twins, they have the same Class 2 Division 2 incisor relationship. So whenever you have an identical twins who has a Class 2 Division 2, the other twin will have a Class 2 Division 2. However, if the twins are unidentical, they found that only 10% of them will have a Class 2 Division 2, which means that there is autosomal dominant inheritance, but however there is more than one genetic factor responsible for that one. So again, when you have a monozygotic or identical twins, all of them will have Class 2 Division 2. That's not only the support of the genetic theory, it's also that patient with the Class 2 Division 2, usually they have a hypodontia as well. So these things that are kind of linked together as genetic inheritance when they come together. Also in the reduction in the lateral incisor size and the width, which is very common in a Class 2 Division 2. Impaction of the canine. Also, we know that palatally impacted canine is due to genetics, and it comes with the Class 2 Division 2, so that will strengthen that the Class 2 Division 2 is highly due to a genetic cause. Other than that, soft tissue plays a major role in a Class 2 Division 2, because we will have a strap-like lower lip, which will cause retroclination of the upper and lower incisors, causing the Class 2 Division 2 malocclusion. And also the lower lip will be resting high above the upper incisors. Usually this lower lip will be sitting on just covering the incisal third of the upper incisors. The crown root angle as well, this is the usually we have the root, and this is the crown, and this angle between them, this is how it normally. However, in the Class 2 Division 2, in some cases this angle will be reduced this way. That will have no stop for the incisors, as we can see here. That will be the anatomy of the tooth. So we'll have lower incisors here, there will be no stop, and they will have overruption, and as well the anatomy of the crown, that means retroclination of the upper incisors. So all these are participate in the etiology of the Class 2 Division 2. So what are the features of this malocclusion? As we do that, usually skeletal, soft tissue, and dental factors. And skeletal factor is anteroposterior, vertical, and transverse. So the anteroposterior, in most of the cases, Class 2 Division 2 is associated with the Class 2 skeletal, as we can see here, mildly Class 2 skeletal. However, Class 2 Division 2 can be seen in even more severe Class 2 skeletal relationship, as we can see here, or even in a Class 1. or class 3 as well. So it can be seen because that will be caused by a local factor. So class 2 division 2 mostly seen in a class 2 skeletal relationship, but it can be seen in a class 1 and class 3 skeletal relationship. So usually these patients will have, as a class 2 division 1, they will have increased cranial base angle, they will have a longer cranial base, they will have mandibular retrognathy. All of these are similar to class 2 division 1. But what is special about class 2 division 2, that the maxilla and the mandible as well, they will be short. But the maxilla will be broader and it will be positioned more forward in relationship to the mandible. And that means that we will have a tendency for a scissor bite. How is that? Now, when the maxilla is positioned more forward, it means that the maxilla is occluding with a narrower part of the mandible. So that will have a scissor bite. And on top of that, the maxilla is wider as well. So when you see a patient with a class 2 division 2, you're going to see that the maxilla is wider on these patients. All of that will help the development of having a scissor bite for this patient. What about vertical relationship? Well, patients with the class 2 division 2, they usually have anterior growth rotation. Alright, and this anterior growth rotation in most of the cases will result in a reduced in the lower anterior facial height, but not all of that. Because sometimes both anterior growth rotation will result in elongation and increase in the length of the ramus, so that the anterior facial height will stay the same, as we can see here. This one will help you to understand it more. If you look here at the mandible, this is the straight line, this is the dotted line. Anterior growth rotation resulted in a downward movement of the posterior side. Posterior facial height, the ramus length is increased, posterior facial height is increased, and then the patient will not have a reduced lower facial height. Usually these patients who has an anterior growth rotation as well, and all these are features of anterior growth rotator, they will have a prominent chin as well, which will mask the severity of the class 2 skeletal relationship. So if the class 2 skeletal relationship is moderate, it will look like a mild one, and if it's a severe one, it will reduce the severity of this class 2. They will also has a reduced conial angle, which is the angle between the ramus of the mandible and the body of the mandible. So, vertical relationship, class 2 division 2 patient, they usually have reduced lower facial height. Not in all the cases, but in most of the cases, they will have a reduced gonial angle and they will have reduced maxillary mandibular plane angle. Transverse relationship is not a big issue in class 2 division 2. What about soft tissue? Yeah, soft tissue is a big issue here. As we said before, the lower lip will be strap-like lower lip, causing retroclination of the upper and lower central and lateral incisors. They will have a high resting lower lip line, because we said most of them, they have reduced lower facial height, and this is kind of explaining to you what do you mean by high resting lower lip line. So usually the lower lip covering only, when the patient is at rest, covering only 1/3 or the incisal third of the upper incisors. But in a class 2 division 2, that due to that the patient has a reduced lower facial height, this lip will be resting high up on the central incisor above at the level of the gingival part of the, or gingival third of the crown. And that will result in, with the strap-like lip, it will result in retroclination of the upper and lower incisors, and sometimes extrusion as well of the incisors. Usually these patients will have a high masseteric force. They have a higher forces from the muscle of mastication. And they, because they have a prominent chin, they will have a marked labiomental fold. This is how the lower lip will cause retroclination of the central incisors. Sometimes lateral escape this one become shorter. They are shorter than the central, so the retroclination will happen to the centrals only. As we mentioned before, as the anterior growth rotation, usually those patients have a prominent chin. And this is very important because we have a patient with a prominent chin, sometimes a prominent nose, strap-like lower lip, pushing all the incisors posteriorly. So if this patient is treated with extraction, there is a risk that we will even dish the profile more. So whenever you see a patient like this, you should be thinking of pushing everything forward to try to give support to these lips, upper and lower lip, to be in harmony with the profile of the patient. Now, the activity of the upper and lower rib will result, as we mentioned, in the bimaxillary retroclination. And here that we mentioned about that care we need to take when we do an extraction treatment, not to avoid this extraction treatment, not to cause dishing in of the patient's profile. What about the dental features? Now, usually, if the lower lip, which is the strap-like lower lip, which is the main etiology of this malocclusion, it's covering the central and lateral incisors, so we'll have retroclined central and lateral and the lower incisors. But sometimes the lateral incisors, because it's shorter than the central, manage to escape the control of the lower lip, so we'll have retroclined upper central incisors only and proclined lateral incisors, which they become mesially tipped and mesiolabially rotated as well. So they will be tipping and rotation. Because of the lips are retroclining the upper and lower incisors, the interincisal angle will be increased. So you see these incisors, they are almost parallel. Now, we know when you do proclination of the upper and lower incisors, the overjet will be reduced. While when we do retroclination of the upper and lower incisors, the overbite. When we do proclination of the upper and lower central incisors, the overbite will be reduced. But when we retrocline the upper and lower incisors, the overbite will be increased. Now, overjet usually reduced because when you do retrocline the upper incisor, you reduce the overjet definitely. And as we said before, the upper incisors become extruded. Now, as any class 2 malocclusion, usually we are expecting that the buccal segment relationship is a class 2, and as we mentioned earlier before, because of the broad maxilla sitting more forward, we are expecting to have a scissor bite in the premolar region. Now, these incisors, they have a reduction in the crown root angle, and also the cingulum is not well developed so that it cannot stop the incisors from over erupting. Now, because of the lips, and the lips are causing retroclination of the upper and lower incisors, the arch length becomes shorter. If you can see here, we drop a line, this one, and the line perpendicular from the incisors, and because of the retroclination, usually patient with a class 2 division 2, they will have a short arch. And the mandible as well, because it's retroclining the upper and lower incisors. However, the maxilla is wider than the mandible, and that will help to develop the scissor bite, as we mentioned before. Now, the patient will have a deep overbite. Now, sometimes this deep overbite is complete, touching the palate, and is traumatic, but not always. Sometimes it touches the palate and causing trauma. Now, because the upper incisors are retroclined, sometimes this trauma will be to the labial surface of the lower incisors, as we can see here. Now, whenever we have a patient with a traumatic overbite like this, treatment is indicated and it's not optional, because there is a risk here on the long-time survival rate of these incisors. So, how do we manage class 2 division 2 malocclusion? Again, these are all the options that we have, except growth modification, camouflage, and orthodontic surgery. And whenever you think about an orthodontic treatment, you need to have these four options on top of your head. Now, how one to decide? It depends on the patient's age, concern, and profile, and we mentioned that and we discussed that in details when we discussed the lecture of treatment planning. So, in the class 2 division 2, just as a reminder, make sure that any treatment you will do to improve the profile. It can be a mild class 2 skeletal, as we can see here, in which you don't want to dish in the profile by the extraction, into severe one that you have to move this mandible forward even with an orthodontic surgery. So option number 1 is accept. If a patient like this and there is no functional problem, there is no traumatic overbite, then why not to accept this class 2 division 2 malocclusion? The other option is to do a growth modification, in which you posture the mandible forward. So if we have a look at this patient, she has a class 2 skeletal. We all agree that she will look nicer if we manage to get this canine, this chin forward. She is 12 years old, she's in the full permanent dentition, she's still in the growth spurt. Why not to give it a go and try to move the mandible forward and stimulate the growth? That will give her a nicer result. However, when you have a patient with a class 2 division 2, the upper incisors are retroclined, which means that you don't have an overjet. so that you posture the mandible forward, as we can see here. So this patient now, as you can see, the upper incisors are retroclined and they're almost touching the lower incisors. So if I decided to do a bite, a twin block, for example, how am I going to posture the mandible forward? So now to do that, we have two methods. The first one is to use URA, in which you procline the upper incisors and you convert the patient from class 2 division 2 into class 2 division 1. And then that's the first stage, and then you move to the second stage, in which you do the functional appliance treatment, in which you posture the mandible forward, and then you go to the third stage, which is using the fixed appliance treatment. And when you are using the removable appliance to procline the upper incisors, usually we incorporate a flat anterior bite plane to control the lower incisors of eruption and to extrude the posterior teeth to help to reduce the overbite. Now, some clinicians, they report that they use a low-ball headgear with this in this stage that will help to extrude the molars to correct the overbite, doing some distalization and restraining of the maxillary growth to correct the class 2 malocclusion. However, usually URA is used in these cases to procline the upper incisors to correct it from class 2 division 2 into class 2 division 1. Or we can use what we call it a modified twin block, in which basically the same twin block is there and we incorporate a double cantilever into this twin block. So as you can see, when you do the bite registration, you estimate how much are you gonna procline these upper incisors and you do the bite registration accordingly. So basically you are registering the bite in a negative overjet. You are registering the overjet in a negative overjet. So basically, you posture the mandible until the overjet is -2, let's say, and then you know that you're going to procline the upper incisors using the double cantilever, so everything should be fine. So the advantage of this technique that you are saving time, because you are not going to do proclination and then functional appliance, you're doing them simultaneously. And also, the patient will not feel uncomfortable, because basically you using a URA, you're going to make him look worse, and then you're going to fit him with twin blocks. So I'm not sure if the patient will be happy. And also about the cost, because you are using more appliances, I personally prefer to use the modified twin block. And then you go to the second phase, as we can say, removable appliance, fixed appliance, and then done with the treatment. Well, as we all know, this is here after we finish treatment. As we all know that functional appliance treatment, mainly dental alveolar, do have a little bit of skeletal relationship, which we can see here. Anyway, growth modification for class 2 has a complete lecture separate to discuss the different types and the effects. But this is enough for this lecture. Now, the other option is to do a camouflage treatment when you do treat a class 2 division 2. So back on the time, Ballard, when he proposed the treatment of class 2 division 2, he said that you can't procline the lower incisors. And why is that? Because if you procline the lower incisors, you are invading the lip space. When the lips are strong, they are strap like lower lip, it definitely you're going to have a relapse. So it's forbidden to move these lower incisors any fraction of a millimeter. What does that mean? It means that if you want to correct the incisor relationship, and most important, you need to correct the inter-incisal angle and to have the lower incisor anterior to the centroid, and we will see now why is that. You need to torque these upper incisors. So you need to intrude the incisors and to torque them, which is very difficult to do. And also you will have the danger that you will move this root outside the bone when you do intrusion and retract and torquing of the upper incisors. Plus, on top of that, that will force you all the time to do an extraction treatment, because in the lower arch, if you have a mild crowding, which is expected because you have retroclined upper and lower incisors, so it's quite often that you're going to go for extraction. And extraction in these cases are really hard, because you will struggle to close the spaces. You might end up retracting in lower incisors and upper incisors, causing dishing in the profile, which we don't want to do that, because all what we want to do is to support this profile, because the patient has a prominent chin and prominent nose. And here Selwyn Barnett came in 1991, and she published a paper in the British Journal of Orthodontics, and she said that we can procline the lower incisors. And the hypothesis was that the space that was occupied by upper central incisors is now will be occupied by the lower incisors, and the lip space will not be invaded. So yeah, you can procline and intrude these incisors because they are overrupted in the upper arch, and in the same time you can procline the lower incisors to correct the interincisal angle, and in the same time the lower incisors will not invade the lip space, because at the beginning this incisor in the upper was holding the lower incisors from the upper and lower lips. So basically what we're going to do is to procline and to intrude the incisors in the upper and procline the incisors in the lower. And this will help you to achieve what we call it lower incisal edge anterior to the centroid by 2 mm. And this is very important to prevent the relapse of overbite, according to Houston in 1989, that if you want to prevent the over-eruption of the incisor again, you need to make a stop between the upper central and the lower central incisor, and this stop is created by Houston suggested that the lower incisors should be anterior to the centroid by 2 mm, while Mills suggested the interincisal angle to be between 133 and plus minus 10, 133 plus minus 10. So when you do treatment planning, you need to consider that you need to avoid doing extraction, especially when you have prominent chin and prominent nose. And not to forget that extraction, if you have to, then do extraction in the upper. Try to avoid extraction in the lower, because extraction in the lower with a high low angle case, they have anterior growth rotation, they have a strong gelmar-ceteric muscle. Space closure is not as easy as we think. So in the lower arch, try not to extract, and even if you decided to extract because of the crowding, need to extract in the lower 5s rather than 4s to make the space closure easier by the posterior teeth moving forward. I never done an extraction in the lower arch with the class 2 division 2 cases. Another bracket prescription: when you have retroclined upper incisors, you need a higher torque to get these incisors into the right place, and the brackets with the higher torque in the upper incisors are the MBT bracket. So here, as you can see, the patient is having retroclined upper incisors with the lateral on the other lateral is flared. Here is the occlusion. Now, back on the days, if you're going to treat this one, you need to take the 4s, because you can't and you're not allowed to procline these lower incisors. Then you will distalize the canine posteriorly. That might increase the overjet. So what used to happen is that you do the extraction, slight retroclination is expected, although you're not planning it, and you need to intrude the upper incisors and to torque it posteriorly to achieve the interincisal angle and the overjet. But nowadays what we do is we do proclination and intrusion of the incisors. As you can see here, they just engage the arch wire will procline the upper incisors, and here's a flat anterior biteplane bonded one used to help to correct the posterior the overbite by extrusion of the posterior teeth. Here the overbite is almost corrected, incisors proclined in the upper and lower arches. However, camouflage sometimes require extraction. As we can see in this patient, the buccal segment relationship is a class 2 on both sides. The lips are thick, slightly protrusive. Upper incisors are retroclined, centrals, while the laterals are flared. In this case, treatment was done with extraction in the upper arch only, not the lower arch, resulted in retraction and correction of the buccal segment relationship. Full unit class 2. So that was camouflage treatment as an option. Last option is surgery. If the patient is not happy with the profile, or he has a severe malocclusion, simply we send him for surgery. First, we have to decompensate him, give him a big overjet, and then he will go and do advancement of the mandible. So what about retention and stability? Now, if we procline the lower incisors and we considered Selwyn-Barnett theory that we are not invading the lower lip space, then, well, proclination of the lower incisors is stable in these cases. However, you always have to consider using bonded retainer and or with or without the CSF to increase the retention of the rotated lateral incisor, because as we mentioned before, that sometimes the lateral incisor become tipped medially and rotated. So if you fix this one, you need to use a bonded retainer to reinforce or to enhance the stability for this kind of malocclusion. It's also advisable that you need to get your canine interincisal angle between 123 and 143, which is 133 plus minus 10, because as you can see here, if you finish the treatment and the interincisal angle is 80, when the lower incisor try to over-erupt, it will slide against the upper central incisor and the relapse will happen. That's the theory introduced by Mills, and what he said is you have to have a good interincisal angle so that it will act as a stop to prevent the extrusion of the incisors and maintain the stability of the overbite. Also, Houston, he said that the lower incisor should be anterior to the centroid by 2 mm, and that will prevent the over-eruption of the incisor. When they try to over-erupt, they will hit and control by the upper incisors. Don't forget that we need a bonded retainer for rotated lateral. Although in this photograph it's 2:2, I prefer for rotation of the lateral incisor to extend this one into the canines. Thank you very much for your time and listening.